Rachel, thank you very much for this is your second work comp webinar. Thank you very much for putting this together and taking the time to help us out today.
Part of these. That's always a nice break from the routine, so glad to be here. This is a little bit about me. I'm not going to go over that, but you have that information. For me, I've always, I'm having an issue here, sorry. There, we're good. During my 25 plus years of performing functional testing, I've been a clinician who's always been focused on making testing better for me, for the clients I test, and the providers who read my reports and the insurance carriers who pay for them. So when I was asked to give this presentation, there were some specific questions I was asked to address. Number one, what do I look for to see if an FCE is good? Number two, what are the limitations of FCE in a workers' compensation case? And number three, can insurance adjusters and case managers, what can they do to be proactive in the current environment? So let's first focus on what to look for to see if an FCE is good. FCEs have been around for almost 50 years, kind of like me. There's been a variety of methods and equipment, and no system has gotten it quite right, or one would have dominated the market. They're different but identical. The biggest differences in different FCE schools of thought are verbiage and the letterhead. And they're really great if a patient is giving a good effort. However, the greatest predictor of the outcome of a functional test is the effort of the person being tested. So let's talk briefly about effort and honesty. Are all injured workers being completely honest? I have been working in the workers' compensation environment for over 25 years, and I think it is incredibly rare to see instances of out-and-out fraud. I do, however, believe that an injured worker can often be motivated by a fear or lack of control over their situation to make their own physical injury appear worse than it may be. This often leads to limitations in effort while in an evaluation or testing situation. Because of potential issues of effort and honesty, when it comes to functional testing, referral sources are often looking for sincerity of effort testing. So sincerity of effort, what is it? Is the client's performance consistent? Is the client's performance reproducible? When asked to perform like or similar tasks requiring the same physical ability, are these results within an acceptable range? We're really looking at the tenets of statistical analysis, reliability, and validity. So how are we going to test for this? There are a few different current practices of sincerity of effort testing out there, and I've listed them here. Static and isokinetic testing are thankfully becoming obsolete because they in no way speak to function. Physiological signs and symptoms. This includes things like heart rate and pain levels. And while heart rate is important to monitor for safety reasons and to make decisions regarding frequent activity, recent studies have proven it cannot be used to determine effort. Pain ratings are also important to monitor during a functional capacity evaluation test, but they're not a measure of effort. Visual estimation of effort. This is where an evaluator is looking for signs of muscular recruitment, those kinds of things. A recent study found that the accuracy of classifying effort using this method was marginally higher than chance. Which brings us to hand strength testing, the good old bell-shaped curve and rapid exchange. To date, there are at least 12 published studies that have shot such serious holes in these indicators of effort that they are no longer considered legally defensible. So now what? What this means is there are a lot of FCEs coming back on problem cases, reporting appropriate effort with permanent restrictions, using unacceptable modes of testing. But don't throw in the towel, because there is something out there that works. XRTS sincerity of effort testing. This is a repeated measures test. Statistical analysis is applied the same in every test. It employs Waddell's concept of distraction and consists of hand strength assessment as well as lever arm testing. We're going to talk a little bit about these things right now. This testing is objective and legally defensible. Evaluators are measuring and remeasuring in a different way. There are established numeric validity criteria that need to be passed. Subjective opinion is removed, making this the first FCE that is truly legally defensible. Testing, as I mentioned, employs Waddell's concept of distraction, which in essence leads to appropriate effort or failure, including a report that takes a stand. Let's talk a little bit about the XRTS hand strength assessment. This is a 66 trial test that involves both upper extremities. Sometimes the client is gripping, sometimes they're pinching, sometimes they're gripping with one hand while pinching with the other. There are 5 different positions used with the grip dynamometer and 3 different types of pinches tested. There are 2 scheduled breaks during the test, which helps alleviate issues that can occur regarding muscle memory if somebody's trying to feign weakness. There are 7 established validity criteria that need to be met to pass this test. This test is 99% sensitive, 100% specific. Out of 200 test sessions, 199 are properly classified, making it 99.5% accurate. It's pretty good. And in the event of invalid effort, you have a report that's going to take a stand. Some statements you may see in a report when there are issues with passing the hand strength assessment would include the following. The XRTS hand strength assessment protocol consists of a total of 66 randomized unilateral and simultaneous bilateral trials. The client failed 3 or more of the validity criteria. As outlined in the user's guide, this result indicates a strong likelihood that the client was not complying with the test, and the test result is therefore almost certainly invalid. Or, on 3 trials of this test, no force production was recorded, and the test was terminated. The test was again restarted, and again, 3 trials showed no force production. This most likely is indicative of blatant noncompliance, and it is impossible to make any comparison to empirically derived validity criteria. Or the client failed 7 out of 7 validity criteria for that XRTS hand strength assessment. The odds of a compliant subject producing the same result are significantly less than 1 in a million. That's some pretty tough stuff to see in a report. Now we also have the XRTS lever arm assessment. Because the hand strength, while it's a powerful tool, it's not appropriate for all diagnoses, and it isn't the most functional of tests. Almost all FCEs include baseline lifting. Baseline lifting is best performed with equipment that is not easily identifiable. This gives the opportunity for the client to go by feel and not their idea of how much or how little they should be lifting. Baseline lifting, when you're going to use the lever arm later, should consist of lifts from 10 inches from the floor, 15 inches from the floor, and 20 inches from the floor for bilateral lifts. There's also an option to do unilateral testing. And then you proceed to the lever arm testing if during baseline lifting the patient did not meet basic job lifting requirements or they're demonstrating inconsistent behavior. When you move on to the lever arm, you're going to repeat a 10-inch from floor height lift, 15-inch from floor height lift, and 20-inch from floor height lift. You may also repeat unilateral lifts if you did those. You're going to want to compare 3 out of 5 of these lifts. And what we're looking for is 20%. They're going to be within 20% of the baseline lifts. That's a valid test. If they're greater than 25% from the values of the baseline lifts, they're invalid. So basically, once the evaluator gets baseline lifting results, they can compare those results to comparable lifts using different equipment where a subject is less likely to determine the amount of weight they're lifting. So instead of lifting with boxes, they're lifting with this. Weight configurations can be changed by adding or subtracting the weight that's on the fulcrum pictured there, or moving the fulcrum forward or back. Clients are tested, as I said, at the 3 different heights by adjusting the chain attached to the handle. So if you had a client that was confused by the equipment you were using for baseline lifting, they're really confused by this. But I want to stress, this is not about confusion or tricking someone. It is about eliminating preconceived ideas someone may have about how much they should lift and how much they want their evaluator to see them lift. Clients are urged during this test to go by how much they feel they can safely lift on each repetition. You know, I'll have clients ask, well, how much is that? And we're not going to talk about that. I just urge them to go by how much they feel they can safely lift. So if we have somebody who is outside of that 25% from what they lifted on the baseline lift, we're going to have invalid findings. This is some of the verbiage you're going to see in a report that would indicate invalid findings. But you're also going to have those people, and honestly, more often than not, that they will be valid. And you're going to have verbiage that's going to help defend those people that are out there and giving a good effort and may need some restrictions. So now we know what to look for to see if an FCE is good. You want legally defensible validity of effort testing. So now let's take a look at some of the limitations of FCEs. FCE tests typically include informed consent, scoring of pain questionnaires, a history, a musculoskeletal evaluation, testing to determine occasional lifting capacities, endurance testing, and a job circuit to not only determine frequent lifting capacities, but specific job testing based on a functional job description. So what if there's no functional job description? And that happens way more often than not. A good functional job description contains cognitive demands, lists of tasks performed, description of work pace, lists of machinery, tools or equipment used, description of the work environment, and most important for an FCE, a good functional job description will include material handling requirements and functional positions with the frequency they're performed. This allows an evaluator the opportunity to have clients simulate tasks. But this is not always possible in a clinical setting. For instance, how do we test this? Or this? Or this? Or this? So while a good FCE is great at measuring sincerity of effort and material handling capacities, many other tasks are difficult to simulate in a clinical setting. So now what? This leads us to our third objective. What can insurance adjusters and case managers do to be proactive in the current environment? I would have you consider the following. Number one, have employers you represent make functional job descriptions available. This helps define the job to medical providers. I'm going to give you an example. Years ago, I had an HR contact at a self-insured company I worked with that would send a functional job description to physician rechecks so that the doctor could circle tasks the employee could perform in a light duty capacity as they were getting better and getting closer to going back to full-time regular duty work. This kind of goes along with the second thing I've listed here. Encourage employers to accommodate light duty or transition to regular duty. We all know the longer an employee is off of work, the harder it is to get them back. The third thing is find an FCE provider that performs XRTS testing. You can go to XRTS.com and find a local provider in your area. I know in my area there are a few that perform this type of FCE. Consider FCE results as they relate to the client's effort and functional status. If you get an FCE report back and there's issues with effort, is this somebody that you're going to consider sending for independent medical evaluation? Or is this someone that you're going to want to send a case manager to the FCE results appointment with a physician so that some questions can be asked? The other thing to do is challenge FCE reports that are using the outdated methods to determine validity of effort I already talked about. XRTS.com also has on their website, I believe, a book that can be purchased that can kind of goes through some of those old modes of testing and how you can defend against those in a legal environment. There are more and more attorneys out there that are looking at that stuff and wanting to kind of shoot some holes in these reports that are coming back saying somebody needs restrictions when maybe they really don't, and we really don't know because there wasn't good effort or it was outdated modes of testing saying there was a good effort, but you really don't know. So those are some things to think about when it comes to FCE for your client population. Does anyone have any questions?
If you do have any other questions about workers' compensation, referrals, or to learn more about our Fast Track program for injured workers, please see our website at orthoillinois.com and click on Employers. In Algonquin, Elgin, McHenry, and the greater Chicagoland area, call Paul Strandquist at 815-847-7088. For Rockford and North Central Illinois, you can call me, Bill Collar, 815-847-7044. So we do have a couple of questions. Ladies and gentlemen, if you would like to type in a couple of additional questions, we do have time to do that. First question, Rachel, what are some of your thoughts on maybe a 1-day versus a 2-day functional capacity evaluation? Is there a difference, and what do you think?
There was a time ago where 2-day FCEs became really popular because the reason being is you'd have somebody come in for a test and they'd say, well, I could do this today, but I'd be dying tomorrow. And so this 2-day FCE concept was kind of started to evolve. And there were some companies that were using this, and then the question became, okay, I could do this for 2 days, but I couldn't do it for a week. So like, I don't know, like, where do we stop here? So my partner at work right here, who I've been working with since I've been a physical therapist, we kind of came up with an idea that we thought would work. We developed a 0 to 10 pain questionnaire that we use during testing, and each number, 0 to 10, is defined. We have a sentence that kind of defines, okay, if you're at a 0, this is what we should be seeing. If you're at a 1, this is what we should be seeing. We chart the patient throughout the course of the test with this pain rating chart. These descriptions of the numbers are in the report, because sometimes you'll have a patient say, well, when I go to the doctor, I would say I'm a 7 based on their pain chart. According to yours, I'd be more a 4. I said, well, it doesn't matter. We'll give them a copy of what these numbers mean. But which is really nice to use during the test. However, what we like to do is at the end of the test, we get a post-test pain rating. And then we give our clients some written instructions to call back the next day at about 10 a.m. and give a pain rating of how they're doing at that time. They're told if you call in tomorrow and your pain level is 2 or more points above what you're saying it is right now at the end of this test, we're going to want to see you. So this accomplishes a couple of things. We also tell them, now you just went through a physically challenging test. What you can expect is throughout the rest of the day, you're going to be more sore. First thing when you get up tomorrow morning, you're going to be very sore. By about 10 a.m., you're probably going to start to see some stability in how you're feeling. So this accomplishes a couple of things. We've got a pain rating of where they're at through the whole test and at the end. And then we've got them calling in and saying, you know what, I thought I'd be really bad, but I'm not so bad. Certainly not so bad I'm going to need to come in and see you again. So it really works out pretty well, because most people, as charming as I try to be, do not want to see me the day after their FCE. So I think that helps answer those issues about what I'm going to be feeling like the next day.
What about validity testing then? If you do have a 2-day FCE, do you test validity on both days if there's a difference, or how does that work?
To be fair, I've never been a big fan of the 2-day FCE because I think it's just the same argument. What about at day 3? If I will say, probably, like, we've been doing this pain rating thing for years, and I can probably count on one hand the number of people who have come back in the next day because of a high pain level. And in those instances, it seemed like they just wanted to talk a little more about their situation. Usually I'll do like a range of motion check and kind of see what they're wanting to talk about. And there's usually no more testing that's done. And then I'm usually getting a pain level of where they're at when they leave. And I think if all their questions get answered, it's all fine.
Got it. If you do have any other questions, please do enter those at this time in the Q&A button. So obviously, Rachel, you've been doing FCEs for a long time. It is a very valuable test for workers' compensation case. What are some strategies maybe the employer or the case manager could use to completely avoid needing an FCE altogether?
I think it's always great if you can avoid an FCE altogether. Ultimately, I think it's important to look for providers out there that are interested in having patients get a full duty release. And there are providers out there who want that. I know at WorkRight, here at Ortho Illinois, our goal for every patient we see when they enter our work conditioning program is we want them to expect they're going to leave with a full duty release. It helps in case closure. It helps in the employer-employee relationship. Or if that relationship, to be frank, is so fractured that it's irreparable, it gives that injured worker more options as they seek alternative employment when they're done with all this. So finding providers out there that are interested in encouraging their patients to take control of their situations and get a full duty release and move on is, I think, your best bet.
Can you speak a little bit to the communication factor between the work conditioning, physical therapy, and the medical providers who are sort of guiding? How important is that communication link, and how often should you be talking to those providers?
Communication is key. I think we're all very busy with what we do, whether you're treating somebody in physical therapy and work conditioning, or you're the physician who's got all these, patients they're seeing on the days that they're in clinic and not performing surgery. So I wouldn't say, there's not consistent communication, but certainly if a work comp patient is going in for that physician recheck, there should be a very good progress note from the therapist that explains where the person's at, where they've got to be, and what are the recommendations to get them that full duty release.
How do you think light duty work then in the process of that employee recovering from their injury? How important is light duty work in helping move that patient or that employee forward and recovering from their injury?
Light duty is I kind of spoke to it in my presentation. Light duty can be incredibly helpful. Just getting somebody back in the door and getting used to a schedule again. The issue is, though, and we see this in our work conditioning program a lot, is light duty should be meaningful. It shouldn't be a punishment. There should be some physical aspect to it versus they have me come and sit in a break room for 8 hours and, shred paper or something like that. Not that maybe that needs to be done, but we'll occasionally have people, that have been referred for work conditioning where we're trying to get them from I can lift 5 pounds to I can lift 50 pounds, and their employer wants them working full-time light duty sitting around. That makes it very difficult for that person to get from 5 pounds to 50 pounds. So I think there should be some discussion, and again, this is my perspective, with insurance carriers and employers of, okay, now that the person's moved on to a work conditioning program and we're doing some light duty, how about, we have the person work half their day at work and then they go to their work conditioning program half their day. And I don't know who pays their wages, whether that's the employer the whole time or comp's paying them for their time in their conditioning program, but these are the kinds of things that's going to move someone from 5 pounds to 50 pounds. A good conditioning program or meaningful light duty at work where they're working up to the restrictions the physician may have them at, and that can gradually increase. There's lots of different ways it can be done, but it's best done if light duty is meaningful.
Again, if anybody does have any additional questions, please utilize that Q&A button to get your questions answered. How you kind of talked a little bit about this, Rachel. How do you help guide that injured employee? How much is too much? We've all seen those employees that have an injury and lifting something incredibly light feels like too much. Yet you also have on the other end of the spectrum those folks who just kind of do what they do and they do overdo it. How do you help that injured employee sort of determine for themselves the amount of effort and the amount of work they need to put in and how much is too much?
I think, it kind of depends on the environment we're in. Like if it's in a work conditioning program, on the outset, there's an orientation where we're pretty honest about the fact that you're going to feel worse before you feel better in this program, but everything that you're going to be doing, if there's something you're starting to feel is unsafe or outside your limits, you have the responsibility of letting us know so we can make adjustments as needed. Obviously, we're clinicians and we would have expectations of what we would see from somebody, but that can always vary. The other, now if you're in a FCE situation, when it comes to lifting things, it's all going to be gradual. You're going to start with a small weight, have a person do a lift, and you're going to say, okay, did that feel safe? And if they say yes, okay, did that feel light, medium, or heavy for you to lift? And then based on their response, you're going to add weight accordingly. Because what you don't want is, you just add a little bit more weight. If it felt light to somebody, if I had just a little bit more weight and a little bit more weight and a little bit more weight, pretty soon, it's going to take me a half hour to get through one type of lift, and they're probably more cardiovascularly taxed than getting an idea of what they can safely lift. So it kind of depends on the environment the patient's in, how they're instructed to be safe, or how much is too much.
Got it. If anyone does have any additional questions, again, please utilize that Q&A button. I will go back to that QR code just in case anybody does want to go on to that functional capacity evaluation. Just go ahead and scan that QR code. You can fill that out and you can get your continuing education. Those were our questions so far. If anybody does have one last minute here, please go ahead and type that in. Rachel, I want to thank you very much for your time in putting this together and agreeing to present this to our work comp case managers and our employers and the adjusters who are on today. We've got a great crowd, so thank you very much for everyone who is joining. I also want to thank my counterpart, Paul Strandquist, for his assistance in getting this set up and helping to let people know. Don't forget, next month, and be looking for these invites, Dr. Neil Shaw will be talking about complex regional pain syndrome. That will be September 29th. Rachel, any last tips and tricks that you could let everybody know about, or things in those FCE reports that should make you raise an eyebrow if you ever see these certain phrases?
I think the slides pretty well covered it, but if anybody does have any specific questions, please feel free to contact me by email, and maybe just put some in the subject line about webinar question or something along that line, so I don't think it's spam and delete it, because IT doesn't like us just opening random things here.
That never happens.
Yeah.
Never does that happen.
But seriously, feel free to contact me via email, rachel.viel, V-I-E-L, at orthoillinois.com, and I'd be happy to try to answer your questions.
And again, if you have any technical issues with the evaluation or anything at all, you can always email myself, Bill C. at orthoillinois.com, or Paul Strandquist, paul.strandquist@orthoillinois.com. Rachel, again, thank you very much for your time. I appreciate you putting all this together. Everyone enjoy the rest of your day, and I thank you very much for your attendance. Have a good day.
Thank you.